Hello, everyone. Welcome to the session of USPED International. Hola a todos, bienvenidos a esta sesión de USPED Internacional. Voy a permitir dar la introducción en inglés por esta gran ponente que tenemos el día de hoy. My name is David Pascual Rojas Flores, a pediatric intensivist from Mexico, and I will be your host today. Septic shock in pediatrics, a topic that you address every day and that continues to cause morbidity and mortality in all children. Dr. Raji comes to teach us, to show us the POCUS approach in persistent or recurrent septic shock. Best fit plus T3, basic echocardiography in shock therapy for fluid and inotrope titration. Dr. Raji is a pediatric intensivist in the Apollo Children's Hospital, Chennai, Tamil Nadu, India. Welcome, Raji. The auditorium, screen, a microphone are yours. Welcome.
Thank you, David, very much. I thank Javier as well for giving this opportunity to share our paper. So, can I start now?
Yes, please.
Yeah. So this is what we published 2 years ago. It's best fit basic echo to titrate fluids and inotropes in septic shock. So it is a layered approach to treatment of shock which persists beyond fluids and vasoactive drugs. Okay. So the objectives of my talk would be like understand what are the complexities in septic shock physiology and see what is the role of echo, basic and advanced focus in not only diagnosis, but also in titrating the therapies. How do we integrate the clinical picture, what we see day to day with echo findings or focus findings? So I have a couple of cases to discuss. And finally, we'll see some pearls and pitfalls of both clinical and focus related pitfalls. So as you all know, shock is circulatory failure where the tissues don't get adequate perfusion. So the oxygen delivery to the tissues may be compromised. Most of the cases, if you see in septic shock, pediatric septic shock or vasodilatory shock, just as we see in adults. So earlier, the septic shock was characterized as cold shock and warm shock. But actually, if you see pediatric septic shock is just like adult septic shock, it's a vasodilatory shock with the element of cardiogenic shock as well, or cardiac dysfunction. So if you look at septic shock, the diagnosis is pretty much easy on clinical examination. So we just look at the pulse, we just look at the heart rate, the blood pressures, and say, yes, this patient is in compensated shock or in hypotensive shock. So we can say he's cold when the peripheries are cold to touch and the capillary refill is prolonged. We say it is vasoconstricted. And we know if he's warm to touch, pulse pressure is wide, then the patient is vasodilated. So it's very easy till at this point, the diagnosis of shock is much easier by clinical examination. But subsequently, as we go deeper and deeper into treatment, things get complicated and clinical findings alone may not be very useful. So we need some more surrogates to help us in management. Another important thing which we have to remember is to identify the reversible etiology. It could be source control or it could be drainage of the fluid, effusions, to name a few. Okay, so as I said, septic shock is a very complex physiology. So there are several problems associated in septic shock. One is the preload, as you can see here. The preload may be low, it may be relative or absolute. What I mean relative is because of the capillary leak, fluid goes into wrong places, or it can be absolute like the poor oral intake or vomiting or GI losses. So the next problem is the vascular tone. The tone can be high, as I described earlier, in cold shock where the capillaries are constricted. You get low vasoconstricted or narrow pulse pressure shock, or it can be wide. So it depends on the vascular tone, which again is mediated. It can be variable in septic shock in children. And the third component is cardiac contraction. So all these parameters play an important role in the physiology of septic shock. So we'll have to remember that it's not simple that you treat one, things get better, then you treat this. So there's interaction of several of these three components, and this makes things complicated. You can see subsequently in my slides, and in some cases, the treatment of one, like say you treat for vascular tone with some drug, preload may get affected and contraction may get affected. So it's very complex situation. We need to precisely treat the problem. So it's not like one size fits all, give fluids, give inotropes, watch, he'll get better. So every patient will behave differently to your treatment. Okay, so the precision therapy or individual therapy is very important. So what we need to do is you need to assess the entire microcirculatory system. It could be right from the heart, the lungs, the venous system, and the arterial system, as I described earlier, the vascular tone, and of course your microcirculation. It's also important that we assess the organ perfusion like kidneys and spleen and the liver, so that we get a clear idea of what's happening to organ perfusion as well. So let's see how the echo or POCUS helps in titrating therapy. So this is what we published, BESTFIT, a tiered approach to persistent or recurrent pediatric septic shock. This is a case series of patients, and we described in detail how interventions can change the physiology and how we need to monitor and how we need to address the underlying problem. So we all know once we diagnose shock, we give a fluid bolus, maybe 10 or 20 mils per kilo. And if the shock persists, we add some inotropes. As described, it can be norepi or epinephrine, either of these drugs, depending on the underlying shock. If it is cold peripheries and cold vasoconstrictive shock, you can consider epinephrine. If it's a vasodilatory shock, you can consider a pressor or norepinephrine. So you may start norepinephrine of 0.05 to up to 0.1, and you may increase as high as 0.2 or 0.3. So what to do if the patient continues to be in shock beyond 0.25 to 0.3 mics per kilo? So we are lost at this point, you don't know whether you need to add another inotrope, we need to give more fluids, or we need to do something else. We don't know. So that's when POCUS comes into picture. So this is what we did in our study. So we assessed in a stepwise fashion. We first assessed the LV function, the right ventricular function, the diastolic function in tier 1 therapy. And in tier 2, we assessed the vascular tone. Okay, basically the stroke index and the SVRI, that is a systemic vascular resistance index. And the third, we assessed the organ perfusion using VEXUS. So if you see in the circulatory system, we all know that preload is very important component. What comes to the right heart depends on your mean systemic filling pressure. So your unstressed volume should be good enough. So once that pressure is high, that is a mean systemic filling pressure, which is generally around 8 to 10 millimeters of mercury. That should be high, and your RA pressure should be low. Normally it is 0 to 3. So a pressure difference between mean systemic filling pressure and the right atrial pressure helps in moving the fluid forward from the systemic circulation to the right atrium. So if your mean systemic pressure is low due to hypolemia, hemorrhage, or whatever decrease oral intake, the preload will be less. So you may have preload deficiency or responsiveness. So it's very important to assess the preload in any patient before blindly giving fluid response, before giving fluid bolus. The next is in the system, we need to assess the contractility, how the heart function is. Is it too good, too bad, or normal? Then, as I said, finally, we need to assess the vascular tone. Okay, so now looking at the Frank-Starling curve, you are all aware that a patient is fluid responsive if he is in the steeper part of the curve. So if you see a patient who has a collapsing IVC, as you see here, with A lines, no B lines in the lung, it's completely clear. We know this patient may be fluid responsiveness. Simultaneously, we look at the heart, and these hearts will generally be contracting very well, hypercontractile, or something called kissing ventricle. This is called the hyperdynamic LV, or ventricles are almost kissing here. You can see in this picture in the short axis. And of course, if you see a nice, juicy, bulky IVC, and if it is associated with the B lines, we know patient is in the flat part of the Frank-Starling curve. And usually these patients are associated with the hypocontractile heart, or the EF may be low. So in these patients, we should be cautious. We shouldn't give fluids. In these patients, they may respond to fluid, that is in the hypovolemic patient or hyperdynamic circulation. So it's very important to know where your patient is on the Frank-Starling curve before you decide to give fluid bolus. So coming to the hyperdynamic LV, so we should know that hyperdynamic LV, the LV is contracting very vigorously. The ventricles are touching, the papillary muscles are touching to each other, and the IVC may be flat or non-pulsatile, collapsing. So you know that preload may be less. So most of the common often we see is hypovolemia, or it may be that not much, what we are seeing hypovolemia is on the left side of the heart. What comes out of the left ventricle stroke volume may be it may be less. So it may be because of the RV failure, or it may be not coming out of the LV. It may be going somewhere. It could be mitral regurgitation, or it may be going into the right side of the heart, that means as in VSDs. Another important thing is the very generous flow from the LV to the aorta. This is what we often see in patients with sepsis who are giving high dose of inotropes, like high dose, like 0.3 of epinephrine and dobutamine and dopamine. So all these, what they do, they increase inotropy of the heart starts contracting very vigorously. So they can cause shock per se, which is called as dynamic LVOTO, which I'll describe a little later. So sepsis, high dose inotropes, tachycardia, hypovolemia are some of the causes for hyperdynamic left ventricle, which you saw in the video there. So how do you differentiate hypovolemia and septic shock? It's important you look at the LVOT, that is a left ventricular outflow tract stroke volume, or VTI, velocity time integral. So what you do, I'll explain later how to do this. So if you put a pulse Doppler across the LVOT, you can get a nice VTI flow. So if the VTI is low, that again, it is age dependent. In adults, it's around 18. But in children, it depends on the age. It can be as low as 10 to 20. So we have age dependent, which you can refer books and see. So if the VTI is low for that particular age and is associated with cold peripheries, that means this patient has hypovolemia as a cause for a shock. On the other hand, if you see a high VTI, patient is vasodilated, warm, cardiac output is high, or the stroke volume is high, that means this patient has high stroke volume, hyperdynamic contract. So a septic shock can have hyperdynamic LV. So we need to figure out whether the patient is hypovolemic or simply the stroke volume is high because of poor vasomuscular tone, that is SVRA is very low. So one you have vasoconstricted shock, one you have a vasodilatory shock. So how do you differentiate apart from clinical findings? It's based on the VTI profile. Okay, so if you find that patient has hyperdynamic LV with the high VTI or the stroke volume, this patient is unlikely to be fluid responsive. On the other hand, if there is hypovolemia is a reason for for shock associated with cold peripheries and low VTI, they may respond to fluid bolus. So this is what happens in patient. I just put an example here. When you give a fluid bolus in a patient who is already vasodilated, the pulse pressure keeps on increasing. You can see so nicely here with the fluid bolus, it keeps increasing. So fluid bolus can increase the pulse pressure or widen the pulse pressure and worsen vasodilatation. So what you do in these patients is you have to be very careful, because once the pulse pressure widens or the diastolic pressure further falls, your organ perfusion is compromised, because you know that the coronary perfusion depends on your diastolic pressure, LVEDP minus your diastolic pressure. So if the diastolic pressures are very low, the organ perfusion, preferably the heart can be worse, compromised. So you may have cardiac dysfunction. So how do we know that? We proved in one of our study that what fluid bolus does to pediatric septic shock. So it has a variable response. This is what we published in PCCM in 2021. So we found that when you give a fluid bolus in pediatric septic shock, it improved the cardiac output and MAP only in 1/4 to 1/3 of the patient. That means out of 100, only 30% improved both cardiac output and MAP. And we saw that not all patients who had increased in cardiac output had an improvement in blood pressure. In fact, we found that many patients had vasodilatory shock after fluid bolus, as I showed in my previous slide. And most of them, 50% of them required pressors. So remember that fluid can be harmful in septic shock if you don't need really. If you give in patients who don't need, you may cause problems in these patients. So you'll have to be cautious in giving fluid bolus. It's not just as easy or simple therapy because you can have fluid overload and other complications, which I'll describe later. So as I said earlier, the dynamic LVOTO, that is when you see here in this patient, you can see there is a contraction very much. So the septum is touching the posterior wall, but at the same time, you can see when the mitral valve is trying to close during the systole. So there's no output from the LV. This is called dynamic LVOTO, dynamic left ventricular outflow tract obstruction. So when this happens because of high inotropes, inadvertently, we try to give more inotropes when the patient continues to be in shock. So a high dose of inotropes, severe tachycardia or hypovolemia may cause dynamic LVOTO. So this you can diagnose by clinically, or you can put M mode, or you can see in the pulse wave Doppler. When you put across the LVOTO, you can see this kind of dagger-shaped pulse wave VTI. So if you see this kind of dagger shape, this patient has LVOTO. So you have to cut back on the inotropes, decrease the heart rate, and you have to consider fluid bolus. So now we saw how to assess preload, how to assess hyperdynamic contraction, and what to do with these patients. Next is coming to contractility. So we need to know how the function of the heart is. Is it good, bad, or too good, which we saw some time back. So you all know there is no standard definition for AF. If you see, none of the papers say EF of this much is hypocontractile, this much is hypercontractile. It's not a standardized definition. That's what I mean to say. And other thing we'll have to remember is EF is very much load dependent. It is very much dependent on the preload and afterload. Suppose if your afterload is very low, the EF can be falsely high, right? So it's very much load dependent. So we can't really go by EF to say whether patient needs inotropes or not. Again, remember it is affected by tachycardia. So how do we assess much more easier way? One is visual gestalt, to look at the four-chamber view, or in the short axis, you see how the heart is contracting, which we saw in a hypercontractile heart. If the heart is poorly contractile, you will see that papillary muscles are not coming closer. The vessels are, the walls are not contracting much. So it's easier to pick up a hypercontractile or a hypocontractile heart. So other easy way to do is to look at the MAPC, just like TAPC, that is mitral annular peak systolic excursion. So you put a M mode in the four-chamber view and see how the annulus moving. The right-sided picture which I'm showing here is the mitral valve annulus movement. So you can see this movement. So measure the distance from maximum to lower here. That gives you the excursion of the mitral valve. If it is less than, again, in adults, it's a standard value. It should be like more than 14 or 15. But in children, it is age dependent again. So anything less than 8 to 6 in infants is low. And so you can see the standard reference for each age group. So if it is low, that means it's much easier to diagnose. If it is low, the patient has LV systolic dysfunction. Just like TAPC, which is tricuspid, right ventricular dysfunction. Again, if you in the same area, if you put a Doppler TDI, you can see a systolic wave and the early and late atrial filling wave. So this indicates, this is a tissue Doppler at the mitral valve. This indicates the S wave, the top one forward flow indicates the S wave. So how good the mitral annulus is moving, this velocity, which is based on the pulse wave Doppler, the tissue Doppler, you can calculate the S wave velocity. If the S wave velocity is generally more than 10, it has a LVF is really good. If it is less than 6, if the velocity is less than 6, that means EF is poor. So these are some of the quick objective ways of measuring your systolic function. Coming to tier 2, next therapy. So we saw we have to look at the LV, we look at the systolic function, we look at the LV systolic function, how it is, and we also look at any pericardial collection before we proceed to step 2. Coming to tier therapy, second tier or diastolic function. So what we do in diastolic dysfunction is we put a probe here at the mitral inflow velocity in the 4-chamber wave, and you measure the E and the A wave, early and the atrial filling. So early filling versus the atrial phase. Normally E is bigger than A. Remember, E and A are load dependent. If your preload is high, it may be high. It may, if preload is less, these values may change. So these are load dependent, so it may not be very reliable in septic shock patients. On the other hand, if you put a tissue Doppler, this is on the right side, again the same area, 4-chamber wave, put a Doppler in the lateral or medial annulus and press the pulse wave Doppler, you get this kind of waveform. This is the S wave which I showed earlier. This is the A wave and the E wave. Okay, so E prime is load independent. It doesn't depend on the loading condition of the heart, simply because it measures the muscle tissue movements. Okay, if myocardial edema is there, it may be low. So E prime is very much load independent. Anything less than 8 centimeters per second, this measurement indicates the diastolic dysfunction. So again, E by E prime, that is E velocity which you get, it may be like, it runs in like 80 to 100. So E, that is early filling, by the E prime will give you indication of diastolic dysfunction, which indicates the LA pressures may be high. So that means the patient may not tolerate fluids, he is fluid overloaded, and he may develop pulmonary edema as well. Usually, if there is diastolic dysfunction and the LA pressures are high, there can be associated TR, which I'll show a little later. The velocity, TR max, that is tricuspid regurgitation maximum velocity, will be more than 2.8 centimeters per second. Okay, so this is how you measure the diastolic dysfunction. Another easier way to do is you put the 4-chamber view, and across the mitral inflow, you put a color and put M mode. So you can see beautifully this blood coming from the LA to the LV, and you measure this velocity speed, that is velocity propagation. If the velocity is more than 50 per second, that is patient is normal, has normal diastolic function. If the velocity is prolonged, as you can see in the right side here, like less than 50 centimeters, that patient has diastolic dysfunction. These are some of the quick ways of assessment of diastolic dysfunction. Although both have fallacies, you need to know the limitations of these. Okay, so you can use color M mode as well to diagnose diastolic dysfunction. So E by, that is early filling, which we saw, which I explained earlier, by the velocity propagation. If the ratio is more than 2.5, it indicates the pulmonary capillary wedge pressure is more than 15 millimeters of mercury. Next, we need to look at the lung. So what kind of lung profile a patient has? Is it all A lines? Is it B lines? Or it is combination of both A, B, consolidation, etc. We also need to look at the pleural effusion, which I'm sure all of you are aware, or pneumothorax. So make sure you rule out effusion, pneumothorax, and type of lung signatures in your second tier assessment. So another thing I want to reiterate here is, in a normal patient, you have no B lines, you'll have A line, and the diastolic function can be normal. So once a patient starts developing diastolic dysfunction, the LA pressure will increase and B lines will start appearing slowly. So at the rest, it may not be appearing. As the diastolic dysfunction worsens or with stress, you can see B lines or more. So this picture where there is diastolic dysfunction but not many B lines on the lung ultrasound indicates hemodynamic congestion. That means patient is congested but is not clinically manifesting or not manifesting in the lung in the form of lung signatures. So this set of patients with the hemodynamic congestion, we should not give fluids here. We should be careful, although patient doesn't have many B lines. On the other hand, as the LVDP increases, if your LA pressure keeps on increasing and worsening diastolic dysfunction, the B lines will start appearing. finally you get a congested X-ray like this pulmonary edema. So this is a final picture towards the end. So it will be too late. So to develop the X-ray finding and multiple B lines. So this is called clinical congestion, where you see on the X-ray completely congested or white out lung or pulmonary edema with multiple confluent B lines. So what is important is here hemodynamic congestion. We'll have to be very careful in these patients. Although the patient has diastolic dysfunction, they may not have a B lines because simply they're in the spectrum of worsening. So you need to identify these and stop giving fluids much early. So coming to tier 2. So we saw in tier 1, we need to look at the IVC, look at the contracting conditions of the left side of the heart, systolic and diastolic. Now coming to tier 2 therapy, we need to look at the RV function. So as I said earlier, the dilated IVC, whenever you see in a patient, you know there is some cardiac dysfunction. It could be left or it could be right. So when you see a dilated IVC, look for the, in tier 1, we saw how to diagnose the systolic function and diastolic. So we need to next look at the right ventricular function. Or you're all aware that right ventricle is smaller than the left ventricle, and it's like 1/3 and 2/3 are LV. So this is a normal function of normal RV. Whereas if the RV starts failing, you can see the size become bigger and bigger. The RV size appears bigger than the LV, and the ratio is like more than 50%. So this indicates the patient has right ventricular dysfunction. So you can put a M mode across the tricuspid annulus and you can get TAPSE, that is tricuspid annular peak systolic excursion. Again, if the values are low, that means patient has RV dysfunction. Predominantly, we assess the longitudinal muscle contraction here. So if the patient has poor RV contraction, that means if the patient has poor TAPSE, it means he has RV dysfunction. We are assessing only one component of the RV, okay, by doing TAPSE. So overall visual gestalt will assess overall the function of the heart, RV. So if the heart is, if there is RV pressure failure, you can see the interatrial septum moves towards the systole, towards the LV. If it is diastolic or volume overloaded RV with failure, you can see during the diastole, the septum will be moving towards the LV. So this is a septal interdependence, which you can nicely make out in your short axis view. I think I have some slides. I'll show that later. So once you see diastolic dysfunction, you need to look at the tricuspid regurgitation jet. So if the blood moves back into the RA during systole, that means patient has RV dysfunction. So you need to measure the TR jet, continuous wave Doppler. And if the jet velocity is more than 2.8, you know the patient has RV dysfunction. So we know now how to diagnose RV dysfunction. So once we know RV dysfunction, you need to know why the patient has RV dysfunction. Is it because of high afterload, or is it just contraction is poor because of sepsis per se? So once what we do is we assess the RVOT outflow. So what you do in the short axis view, plaques or PSAX, parasternal short axis RVOT view, you get this beautiful Mercedes-Benz sign. So you get this RA, RV, and you can see here pulmonary artery. So Doppler that area, pulse wave Doppler at this juncture, if you put, you get a nice, beautiful VTI profile. Okay. So this is just like LVOT VTI, we get RVOT VTI. Normally the RVOT should be like tongue shaped. It should be a smooth downward trend, upward trend. This indicates the lung pressures are normal or PA pressures are normal. Okay. The normal value, again, velocity VTI should be around 18 to 20 in adults, but again in children it is age dependent. Another thing is we measure the pulmonary exhalation time, PAAT. So from here to here, the peaking of the VTI from the beginning of VTI, this distance gives you PAT. It indicates how much the afterload to the RV is. That is the PA pressures. So you can see various profiles of the RVOT VTI profile. This looks normal in picture A. In picture B, you can see in the second one, you can see the PAT is getting increased. It's less than 100. Normally it is like 120. If it starts decreasing, that means it is early exhalation. That means the PA pressures are high. And you can see systolic notching in patients with very high PA pressures or even in embolism and things like that. And if it is very rapid uprise, that means PA pressures are very, very high. This indicates RV-PA decoupling. You know, the cause for RV dysfunction here is high afterload. That is a pulmonary pressures are high. So once you know all that, you need to assess what if the IVC is full and RV dysfunction, you need to assess the venous system. Okay, that is called VEXUS, venous excess by ultrasound. So normally you look at the IVC first if it is like more than 2 centimeters in adults, or if it is much bulky and no respirophasic variation, you need to look at the hepatic vein Doppler, which you can refer to standard books and see how to do hepatic vein Doppler. Normally you get a wave atrial contraction and S and the systolic wave and the diastolic wave. In RV dysfunction, or you can see the S wave becomes smaller as seen in this picture, and in further worsening or venous excess or venous congestion, you can see D only wave, S reversal and D wave. So you have various grades of abnormal hepatic venous Doppler. Similarly, we have portal vein Doppler, same area in the right infraclavicular or in the axillary area. You put the pulse wave Doppler on the portal vein. You can see a continuous flow. Normally, it is a continuous flow. If the patient has high venous congestion, you can see pulsatility, as you can see here. Anything more than this, somewhere around 30%, and this will be almost 100% in this picture which I'm showing. So this indicates higher severity of the venous congestion. Next is the renal. Renal Doppler, you can see on the top, you can see the renal artery or the interpapillary muscle artery interrogation. You can see the renal resistant index on top. Down, you can see a renal venous flow, which is a continuous flow. If there is severe venous congestion because of the because kidney being an encapsulated organ, you can see a systolic and diastolic splitting. Not continuous, it becomes S and D separates. And in even worsening severe condition, you can see D wave only, S wave will be up. So these are various phases of venous congestion, which can be responsible for organ hypoperfusion, and there can be macrocirculation can be normal because of fluid overload or RV pathology or uncoupling, which we saw. There can be venous congestion and organ hypoperfusion. So why is it important? VEXUS is important in septic shock. Organ function can be impaired. Tissue perfusion, it can have tamponade-like effect in tissues. Venous pressures can be high. So perfusion is decreased to the organ. You may have organ failure. So it's important to assess hemodynamic coherence using organ Doppler. So this is what we studied in our cases and patients with right ventricular dysfunction. We found that high VEXUS score was associated with high incidence of kidney injury. Portal vein is the best predictor of kidney injury. And we saw that with improvement in treatment in right ventricular function, VEXUS score improved and patients got better. Okay, so putting it all together, if the IVC is small and your portal vein is normal, patient can be given fluids. On the other hand, if patient has IVC collapsing, but there is a severe abdomen distension, if you see portal vein being normal, you can give fluids. Or if the portal vein is showing some pulsatility, that means you should be careful. So what I'm trying to say here is IVC can be a false marker. It can be collapsed in patients with severe abdomen distension. Patient may or may not need fluids. So we need to look at portal vein as well to see if patient is really fluid overloaded or he's hypovolemic. Okay, if the patient has pulsatility in the portal vein, you'll have to be careful. Don't give too much fluids. On the other hand, if your IVC is dilated and you see portal vein pulsatility like this, don't give fluids in this patient. You need to give some inotropes or diuresis. Coming to the last thing, contraction. We saw the contraction. We saw how to assess the LV, how to assess B lines, contraction, LV and RV contraction, diastolic function. Next, coming the vascular tone. Okay, the vascular tone is very simple. As I described earlier, if the patient is vasodilated, pulse pressure is wide, patient is in vasodilatory shock. If he is cold, capillary relief is prolonged, patient is in vasoconstricted shock. You can see your wide pulse pressure on the A-line tracing, 106/30. So when you say pulse pressure is wide, if the diastolic blood pressure is less than half of the systolic BP. Suppose your systolic is 100, and if the diastole is less than 50 millimeters, half of systolic, less than 50. So patient has 100/30. So this patient definitely has vasodilatory shock. If you have a non-invasive cardiac output monitoring, which we use in our unit, this is the bioimpedance method of checking. So you can use any of these, or you can even use invasive as shown here, flow track. So if you don't have any of these monitoring system, you can just go by pulse pressure and clinical examination alone to characterize the patient as vasodilated or vasoconstricted. So you can calculate on echo as well, the cardiac output, just like I said, VTI. You calculate the VTI on the 5-chamber view. This is a LV, LA, RA, RV. This is the aortic outflow. Put a Doppler here and you get a beautiful VTI. So you know the VTI. So now stroke volume you can calculate from the VTI. That is VTI is times the LVOT area. Calculate the LVOT area, diameter, get the radius of this, and you get your stroke volume using this formula. So cardiac output is heart rate times the stroke volume. And you know that systemic vascular resistance is MAP minus CVP over cardiac index. So distributing these values, you will get SVRI. So echo can be used to calculate the SVRI as well. So once you know the patient has vasodilatation, you know inotropes have to be started. Pressors are the best drug like norepinephrine. Simply it increases SVR, improve MAPs. Norepinephrine also increases the venous tone and improves venous return. It also has mild inotropy and improves the contractility as well. So by adding norepinephrine, you can balance flow and the vascular tone as well. So a combination of a small fluid bolus or pressor is a very good combination. It helps in improving not only blood pressure and SVRI, it also avoids overzealous treatment with fluids. So a small amount of fluid bolus with pressor corrects hypotension, limits fluid overload, and also less hemodilution because you're not giving much fluids with early norepinephrine. Okay, so what happens if you give too much of vasopressin or norepinephrine? So the heart starts contraction can starts failing. So this is called ventricular-arterial coupling on the left side. So basically for the cardiovascular system to efficiently or effectively function, the heart efficiency should be good and the aortic efficiency should be good. They should go together, they should match each other. Suppose the arterial tone is increased or the elastance is high and the LV elastance is low, patient can have uncoupling. There is a mismatch between the heart and the aorta. That's when you get shock. So you can calculate the ventricular arterial coupling on echo. Basically, you calculate the arterial elastance, that is EA, based on your systolic BP and the stroke volume, which you can get from your LVOT VTI. And you can calculate the LV elastance using the systolic BP and end systolic volume. Ratio of systolic BP over the end systolic volume will give you LV elastance. This you can get from your echo, Simpson's method, you can get your end systolic volume. So normally the coupling should be good. It should be 1. The ratio should be 1. If the ratio is abnormal, that means patient has failing heart. Suppose you give high dose of pressors, you know that patient is contractions can fall and stroke volume can decrease. So it looks very complicated, isn't it, at the bedside to do. So what we see often is when you start norepinephrine in any patient, this is what a cardiac, I've just given an example in one of our patient. After starting norepinephrine, the stroke index was very low, SVRI was very low, 700. SI was 57, that is stroke volume was 57. After starting norepinephrine, we saw the SVRI increased very nicely from 700 to 1700, but the stroke volume and inotropy decreased. This indicates that norepinephrine is not helping the patient, it is worsening. So we need to back off norepinephrine dose, or you may have to add some inotrope. This is called ventricular arterial uncoupling with treatment. So this is how the clinical examination may not be alone, may not be sufficient. You need some kind of monitoring to calculate the to know the effect of drugs on heart and arterial system. So you know that high dose of norepinephrine may improve. If it doesn't improve, you can see a fall in stroke volume or even hypotension with these patients with high dose of norepinephrine if the patient has is worsening on high dose of norepi. So this is a very useful tip at the bedside to decide whether to add a new drug or to back off existing pressors like norepi. Okay, so this is completes the entire circle. We check the tier 1, we check the for effusion, pericardial effusion, LV systolic, LV diastolic. We looked at the LVOT VTI and how the shape of the VTI is. Next, we look at the lung signatures, look for any effusion or pneumothorax. Then on the right side, you look for the RV function, RVOT VTI and VEXUS. And finally, you look at the vascular tone, which I described. You can even look at the splenic index. I didn't mention here. You can even do the splenic Doppler. It indicates the macrocirculation. So now we saw how echo helps in diagnosis and titrating therapy. Next, we'll run through some case scenarios. So this is a child with dengue fever who was very sick, who came in organ failure, liver failure, coagulopathy, and severe AKI. She was very tachycardic. I mean, cold vasoconstricted shock. I don't know how many of you see so severe dengue in Latin America. We often see children with in coming in this picture. Severe metabolic acidosis, lactates were very high, creatinine was high, okay, and child came in shock and we had to resuscitate during the critical phase with lot of fluids, around 3 liters this child got. Finally, she started to have tail worsening urine output, AKI, so we had to start dialysis. Okay, so shock got better in 30 hours. But soon she developed new fever, respiratory distress and shock. So she was intubated for that. And she was on high ventilatory setting, PEEP of 13. During dialysis, the fluid removal was around 1.8 liters in the past 12 hours. Lines were placed, new lines, and antibiotics were escalated. So what do you think is the cause for hypotensive shock in this child? Oh, this is a monitor of the child. So she's, how old is she? 8-year-old. So she's very tachycardic and hypotensive, CVP of 7. Lactates are better, but still she's in very bad hypotensive shock. What do you think is the cause for shock in this child? You can see she's ventilated with high vent setting, lot of pulse pressure variation, CVP 7 only, SATs are around 88, very tachycardic. So fluid removal of 1.8 liters. So what could be the potential cause for shock in this child? So we thought, is it hypovolemia because we removed around 1.8 liters of fluid, or is it because of high PEEP causing decreasing in preload and hypotension, or is it cardiac dysfunction, or is it new septic shock? We don't know what it is. So we didn't know what it was. So somebody said that there is pulse pressure variation and a lot of fluids were removed during dialysis. Let's give some fluid bolus. So fluid bolus was given and you can see there is fall in BP further. From 70, it became 67. There was desaturation. Heart rate continued to be same. But the patient had rise in CVP from 7 to 13. So this clearly indicates that patient fluid was not a good choice. In fact, patient got worse with fluid bolus. So why do you think the patient got worse with fluid bolus, despite being 1.8 liters negative? So it is a biventricular response. You can see in this picture. So this patient basically had collapsing LV and the right ventricle was big and is compressing the LV. So this indicates the RV was failing. So the pulse pressure variation which we saw on the monitor is indicator of RV failure. So it's a false positive sign. In these patients, you can see the compressing here. The septum is moving towards the LV. So the cardiac output definitely will decrease. That's why the patient had shock. So in these patients, if you give fluids, it made things worse because RV becomes much bigger and bigger. So you should avoid fluid bolus in this patient, even though there is pulse pressure variation. Instead, what we did thorough evaluation of entire system, which we described earlier. The TAPC was low. It was very low. RV dysfunction was severe here. And the S wave was small. And we saw already that the septum was moving towards the LV and the RVOT profile PAT was very low. So with this, we got to know the patient had high right ventricular afterload. So we started nitric oxide and decreased the PEEP. With that, it got better. You can see the RVOT got very better. Hypotension improved. So the cause for hypotensive shock in this patient was not fluid removal. It was basically severe RV dysfunction secondary to high intrathoracic pressures and ventilation. Okay, coming to second case. This is a 6-year-old child who has septic shock and organ dysfunction. Abdomen was a focus. Laparotomy, bowel resection, anastomosis was done. And he was started on high dose antibiotics and steroids. He was on second day of post-op period. He was around 2.8 liters positive. He was on high dose of norepinephrine 0.3 and epinephrine 0.3. He was continued to have tachycardia, cold peripheries, very prolonged CFT as you can see here, and lactates were high. So this is what the BP is hypotensive shock with tachycardia, with high dose of inotropes. So what do you do in this child? Why is he continued to be shocked despite very high dose of inotropes and lot of fluids already? So is it myocardial dysfunction? Is it so? Should we add another inotrope? Is it hypovolemia? Or do we need CRRT? Or is it new focus? Should we ask surgeon, repeat a CT and do any source control again? So we don't know. So we did echo in this patient and we saw again hypercontractile RV here. And this time you can see this, dynamic LVOTO. Beautifully, you can see the LVOT was obstructed because of high dose of inotropes. 0.3 of epi and 0.3 of norepi, and also had multiple B lines. So this patient had dynamic LVOTO. So we had to give some fluid bolus to improve the preload. Okay, and we had to cut back on the inotropic agents. We decreased the dose of inotropes and added dexmedetomidine in this patient. So we decreased epinephrine, gave some fluid bolus, and started rate control with dexmedetomidine and ivabradine. So things got better. So this case was clearly not so clear at admission, at presentation, but with echo, we found that he had dynamic LVOTO. That was because of high dose of inotropes. So why did this patient have multiple B lines? Because whenever you have a dynamic LVOTO, there's no outflow from the LV to the aorta. So what happens is the LA pressures will start increasing, high LV filling pressures and MR. These patients will have B lines. So never diurese these patients who have even the B lines are more, or if the patient is desaturating, don't diurese, because the moment you treat your LVOTO with fluids or decreasing the inotropes or some pressas, the dynamic LVOTO will disappear and the LA pressures will come down. So never diurese patients with LVOTO with high filling pressure, because the treatment of LVOTO itself will treat your high LA pressures and fluid overload in the lung. Okay, finally, some pearls and pitfalls. Remember, always shock, micro and macro discordance can be there. Your macro circulation can be better. Blood pressures are good. Heart rate is good, but continues to have cold peripheries, high lactates, urine output, maybe not assessment. So remember that there is a mismatch between micro and macro. Always they're sensitive to diagnose clinically, but it may not be specific for hypoperfusion. So you know that oliguria is bad, but we don't know why is it bad. So we need to look at the Doppler evaluation to look at the renal and splenic indexes to know whether any organ hypoperfusion, as we saw in VEXUS. So further detailed assessment is required. Simple micro macro discordance can be there. We need to assess thoroughly before we need to assess even the mismatch in the micro and macro circulation using Doppler studies. Second pitfall is hemodynamic variables can be clouded by medications. What I mean to say here is some patients who are on alpha agonists like dexmedetomidine or beta blockers or sedation, they may not have tachycardia. So don't ignore these patients. Look for other features of shock for diagnosis and monitoring. Number two is some patients can have shock despite normal heart and high dose pressors. So when you see sometimes that patient with very high dose of vasopressin or norepinephrine, heart is normal, sometimes they continue to be in shock. So what you do in these patients, you can start some low dose epinephrine, and most of the times child will get better. So consider inotrope challenge in persistent shock despite normal LV and RV, especially those who have lowish heart rates. Okay, so it may be beneficial. I remember the Doppler problems when get a good view first before you analyze your Doppler envelope and treat your patient. Make sure there is a good view before you interrogate a Doppler study and interpret it. Or always remember, high LA pressures is not always diastolic dysfunction. It is in volume overload patient, despite normal LV, you can have high LA pressures. On the other hand, in hypovolemia, LAP can be low despite normal diastolic function. So again, cardiac output, there is no one single number. We need to go by the trend. It, as you see, sometimes in cardiogenic shock or chronically congestive cardiac failure, the peripheries will be, patient can have low cardiac output because the patient is used to the system and he can still have normal perfusion. So it's no single value in cardiac index. We need to go by the trend. And always remember, whenever you treat the patient, there should be improvement in cardiac index, not just improvement in blood pressure. Abnormal Doppler pattern is not specific for congestion. This is especially in patients with thrombosis or hepatic disease. You can have false positive hepatic Doppler changes. Raised abdomen pressure, IVC can be collapsing. And in many adolescents and hyperdynamic states, pulse pressure, portal vein pulsatility can be more than 50%. So what is the final slide? Key message: septic shock is multifactorial and complex. Always do echo and Doppler studies. It's very important to know the precise diagnosis and therapy. Make sure your echo interpretation should be based on clinical context. Always correlate with clinical findings. It's not a binary decision. This is there, do this. So you correlate with clinical findings and then treat. Remember, there are several limitations with echo. Always trend in numbers are more informative than just absolute numbers. I think I'm done with this.
We just had an amazing session. Thank you so much, Raji. Hemos tenido una gran sesión. Muchas gracias, Raji. And we have some questions for you.
Okay.
First, let me begin with this. What is the most difficult part of learning to do BESTFIT?
I think everything is important, when you try to do LV function, you need to get a good chamber view. There should not be foreshortened view. I think getting a good basic view is very important, because if you do some foreshortening, if you tilting, rotating, all those should be very appropriately done. If you misinterpret an image, you may get a false finding. Just like IVC, you have cylindrical effect. If you keep doing if you just take a longitudinal view, and if you see IVC, in some view, it may be collapsing because of cylindrical effect. In one, it may be opening. So it's very important that you get a very good image, ideal image, before you interpret. So once you get a good image, I think interpretation is just easy.
Great. Yes, you have all the reason. The Phoenix criteria. Will the Phoenix criteria of sepsis change anything in the BESTFIT?
Nothing. This Phoenix is only for diagnosis. It has nothing to do with the Phoenix criteria. It's for it's basically to diagnose the problem, not change any criteria in the Phoenix.
Great. Raji, do you think the BESTFIT plus T3 will receive any modifications in the future?
Yeah, it's a good question. I think we have just included the ejection fraction and the RV function, which are not ideal measurements to do really. It's not the ideal way of checking LV function or RV function. But I think the bedside, that's the simplest way of doing. So I think going further, we need to look at the organ perfusion like splenic Doppler. And we underdiagnose LVOTO, I think. So something which we need to look, because all of us are aggressive in sometimes, we go on high dose of inotropes, especially epinephrine. So that can cause tachycardia and, outflow obstruction. So we need to be careful. We need to incorporate, I think. It's been more and more proven or been diagnosed in adults, but I think in children also it is the same. We are just not diagnosing it. We say, okay, this child is not responding to high dose epinephrine or norepinephrine. On the other hand, we may be harming them by giving high dose. So we need to look into the problem rather than just keep on increasing the dose of vasoactive agents. In fact, we had some referrals saying for ECMO, saying that patient is in shock despite 0.5 of epinephrine, 0.5 of norepinephrine. And we just did echo and brought down the heart rates by decrease. And we found dynamic LVOT and decreased the dose of inotropes, things got better. So I think many a times I'm not saying not all patients of I mean, some may need ECMO, yeah, but we need to figure out the problem rather than just go on ECMO on high dose pressor. So many a times we create problems. So always less is more in these children. I think as we go forward in the BESTFIT, we may have to include RVOT profile, LVOT profile, and also the organ Doppler in detail to complete the whole system circulation.
Renal resistance index, Raji.
Yeah.
What do you think about of this index?
The renal resistance.
Yes.
See, the renal resistance index, again, there are several systemic variables which can change the RI, like hypoperfusion, the pulse pressure, the diastolic BP, tachycardia. All those can change the RI index. So I don't think so a single number is useful. So if the macro circulation, if the BP is good, I think we should not handle much. But if there is severe venous congestion, also the RI can change. So we need to interpret in the clinical context. Is the patient hypotensive? In fact, sometimes what we do is we keep increasing pressors like norepi and vaso and see the RI will start getting better. RI can be high above 0.7 or 1. And once you start pressors, you can see the RI getting better. That means you're simply improving the perfusion to the organ. I'm trying to say in the macro circulation side, the arterial side. So if the RI is high, it can be arterial hypoperfusion, kidney hypoperfusion. So improve the perfusion of the kidney by starting pressors. You can see the RI getting better. So it's one way of looking at it. It can also be high because of back pressures from the right side of the heart. So when there is severe venous congestion, also RI can be high. So we need to look, why is it high? Why is it abnormal? Is it because of arterial side or the venous side before we interpret and intervene the finding?
Yeah, the Venous side is very important. So a final question, Raji, why people should learn to do BESTFIT?
So the whole thing is sometimes, as I said earlier, you can start fluids, norepinephrine, some dysfunction, we start epinephrine and vasopressin. So when you're doing so many things at a time, you don't know why the patient is in shock still. So it could be, as I said, several reasons. It could be not just LV systolic failure, it could be diastolic failure, it could be RV systolic failure. It can be like LVOTO, which I explained. So we need to find the cause of shock rather than just keep on increasing the inotropes or keep giving fluids. So I think it helps in precision therapy. It's like each patient may need a different treatment. So blindly we can't give drugs like in a guideline say, so you say either say like start epinephrine, no response, add norepinephrine, cold peripheries, add dobutamine. So it's easy, but I think each drug itself can harm and make things worse. So I think it's for patient-guided therapy, we need to use BESTFIT.
Yes, amazing. That's right. The BESTFIT, it's a part of POCUS that we need to learn and make it every day. Thank you very much, Raji. The entire USPET team, thank you. We would like to invite you again. Any last words?
Okay, thank you. I hope it was useful.
No, it's all useful.
Okay, fine. Thank
Muchas
you very
gracias.
much. Thank you very much.
Thank you, Raji. Muchas gracias a todos ustedes. Esta ha sido una excelente sesión de USPET con la doctora Raji desde India. Un saludo a todos y nos vemos en la próxima sesión. Esta sesión va a estar en el canal de YouTube en el canal de Spotify y síganos en las redes sociales para las siguientes sesiones.
Thank you.
Thank you, Raji.
Bye. Have a great weekend.
Yay.
Thank you.